There's a slight change in the order because the speakers are coming now. Subluxated traumatic cataract is definitely a challenge which we'll have to keep in mind. The exact ways of exact surgical strategies that we should adopt. Now here, if you see, this vitreous anti-vitrectomy is going on, and then after staining the capsular rhexis has been done. Now using the direct vertical chop, I am emulsifying the fragments. Surgery was going on very well. You see the two capsular hooks that were placed to support the capsular bag, and throughout I was injecting viscoelastic substance to see that the posterior capsule won't come into the phaco-tip. So surgery was going on very well. It was a soft cataract and a relatively young patient. So at one point of time, the vitreous came to the phaco-tip, so I had to stop. So this means there was a pre-existing rent which we could not identify. Then dry anti-vitrectomy was done. Here one should not do bimanual anti-vitrectomy because there is a possibility of these fragments to go down into the vitreous. Then they remain under the cover of the dispersive viscoelastic like viscoat. I have no financial interest. You can emulsify other fragments, keeping the parameters low, and then every time you inject viscoelastic substance before you withdraw the phaco-tip, and then using a single cannula, the remaining soft cortical matter was aspirated. So now here the zonules were weak, and then there's a rent you can make out. So this bag had to be fixed to the sclera, so you can't obviously put a Cione ring or a CTR. So I am using a capsular tension segment of Ahmad and then suture it to the sclera there. And now this area is secure, so we can place a 3-piece hydrophobic IOL in the sulcus. Since this area is totally covered, the zonular adhesions will not allow the haptic to migrate in that area. So you can comfortably place lens in the sulcus and capture the optic in the bag because the rhexis is still intact. So the take-home message here is, even if there is a rent in the presence of zonular dialysis, one can still fix the bag to the sclera with the help of CTS segments, and then of course we will have to follow all the principles of doing proper vitrectomy. This is another case where if you see there is a zonular dialysis, and you can see it's extending from here to here. So anterior capsule was stained with the trypan blue. One problem here is the blue dye may trickle into the vitreous, and thereby the fundal globe becomes difficult. Now using visco cannula as a sort of visco pump, trying to complete the rhexis with the help of rhexis forceps. The capsular rhexis in any subluxated cataract has to be at least 4.5 millimeter in diameter, so that there should be 1 millimeter of the capsular fornix where you can place the thing, and then if it is too small, then it will be very difficult to use the capsular hooks. So now hydrodissection is very important. You have to mobilize the nucleus properly, and then once it is done, here the endocapsular tension ring is going into the bag. This is may not be a correct idea because this is not going to stabilize the lens, stabilize the capsular bag. It can center the bag in this proper place. Now, so the bag has to be supported with the help of either iris hooks or the capsular hooks. Capsular hooks are better because that it has got a bend, and then it pulls the bag towards the equator, the lens equator. Then surgical principles depending upon the density of the cataract. So here it was very soft, so I could aspirate the cortex and remove these iris hooks and then place lens in the bag. So this way the surgery can be completed. Only thing is we'll have to keep all these all the steps in mind, and then so the incision should be away from try to be away from the zonal area of zonal adhesions, and then bag place IOL can be placed in the bag or can be fixed to the sclera, or you can place a AC IOL. Results are good. So proper evaluation, proper surgical strategy, ability to implant IOL in the absence of capsular support should give you good results. Thank you very much for your patient listening.